Welcome to the atelectasis lecture. So this one, pretty short presentation overall. Atelectasis is usually the result of something going on. It could be either contraction atelectasis, resorption, or compression atelectasis. So we'll sort of look at all three different things. So you're going to sort of treat them a little bit differently. The idea is that we somehow need to get that lung tissue re-expanded. Because as we talked about with the pneumonia presentation, and that lung tissue collapses and it stays collapsed, not only does it decrease your ability to get oxygen into your bloodstream, but it also increases your likelihood of developing a pneumonia. So when we see atelectasis, we need to somehow find a way that we're going to help resolve it overall, and then the method that we pick to help resolve or to be therapeutic with it is going to sort of depend on which type of atelectasis they have. So it's kind of important to understand what is going on, what's causing their atelectasis. Now sometimes people will be unresponsive to therapies for atelectasis, and that may be when we have to go in for a bronch. If we have unexplained atelectasis that's unresolved, then that may be an indication for a diagnostic bronchoscopy, because there could be a lesion or a tumor, or there could be something there that's actually blocking the ability for gas to go into that area. And so that's something that we might have to look at down the road. Sometimes it's a giant mucus plug, and that's when you so have to instill some acetylcysteine or something like that directly onto the mucus plug, or see if you can just aspirate it first. But so knowing the cause, knowing what type of atelectasis it is, and then we can sort of make a treatment plan is going to be sort of a big benefit here. So when we're looking at atelectasis, it's an abnormal condition caused by the collapse or total collapse of previously expanded alveoli. So that means some of your alveoli just collapsed in on itself thanks to Laplace's law. Surface tension increased to the point where it's a lot easier for it to stay closed than open. So this ultimately results in poor gas exchange, right? Their CO2 levels are going to be higher, and their oxygen levels are going to be lower in that area, so that's going to cause their whole body to sort of suffer from this. So atelectasis in itself, it is not a disease, right? But it's usually the result of something else going on. So we talk about it in disease class, however, it's not a disease into itself, but left alone, it can fester into something like a pneumonia, right? With patients that have atelectasis, their lung compliance is reduced. So that means if you were to hook them up to a mechanical ventilator, it's going to take a lot more pressure to open up their lung tissue. It's going to take a lot more pressure to deliver that breath, right? Their lungs are stiffer. It's harder to push open those respiratory zones, right? Because that area is collapsed in and has higher surface tension. It's going to be a lot harder to expand their lungs. So even if they're not on a ventilator, if you have atelectasis, your negative pressure that you're using with your thoracic cage can actually cause you to work harder to breathe. You're going to have to use more of your respiratory muscles, your accessory muscles. You're going to have to work your diaphragm harder to create even more negative pressure just to get that regular breath in, because the compliance is lower. So typically, and we talked about this in pulmonary A&P, when the compliance is low, because you can't take a deep breath when your compliance is low, your respiratory rate tends to go up. And I hope you remember the compliance rate relationship. I know you guys all remember this and you look over those notes daily. But that's what you're looking at there, is usually when their compliance is lower, they'll be more tachypnic because they can't take that breath in. So there's three types. We just talked about them a little bit. Post-operative or primary or resorption atelectasis. The second type is passive or absorptive atelectasis. And the third one is compression atelectasis. And compression is the easiest one for me to remember, but we'll go through all these. Hopefully you'll remember which types. These sound like good test questions. Just saying. Which type is this, which type is caused by this, so on and so forth. Here we go. All right, so this is a picture from your book of the different types of atelectasis. We have the alveoli and postoperative atelectasis with A, where you have total alveolar collapse, and B would be partial alveolar collapse. Postoperative atelectasis, remember when someone undergoes general anesthesia. No, we're not talking about like a local and sort of a numb or a spinal block or something like that. We're not talking about that. We're talking about general anesthesia when we're looking at atelectasis in general, because they use nitrous oxide as part of their anesthesia gas, and the nitrous oxide is actually lighter chemically than oxygen, which has nitrogen, than the gas mixture that we normally use for ventilation, which includes nitrogen, right? Air is mostly nitrogen that's around you. So these are lighter gases. The nitrous oxide, sorry, not nitric, but nitrous oxide, there's a difference. The nitrous oxide is a lighter gas, and it actually can flush out the nitrogen. So what happens is the nitrous oxide goes in, flushes out all the nitrogen that's in the lungs that is a heavier gas. It flushes them out, which means there's less of a distending pressure inside the respiratory zone. There's a lot more atelectasis ability here. Not only that, but after general anesthesia, are you going to be taking ginormous, big, deep breaths? No, right? Usually you hypoventilate. Usually you're not expanding your rib cage very well right after a general anesthesia procedure. So both the type of gas that they use, combined with probably the paralytics as well, that are wearing off, are going to make this person more likely to have alveolar collapse. So that's why post-operative pulmonary infections are a thing. Not only is your ability to expand your lung tissue impeded, but your ability to clear secretions, right? We talked about that with the cilia and positive pressure ventilation, as well as the cilia and paralytics. Mucociliary clearance is impeded as well when you have low lung volumes, right? Because you're not breathing in deep and back pressuring the secretions, right? You spend twice as long in exhalation as you do in inhalation. If you're not taking a deep breath at all, then you're not getting as much back pressure to have the secretions move up the escalator and out. So that's one of the reasons why post-operative prevention of a pulmonary infection are going to be big, big things. That's why people will do NEBs for 24, 48 hours after a general anesthesia procedure, because they want to get the lungs open and moving again so they don't develop a pneumonia. All right, so anatomic alterations with atelectasis. The big thing is going to be the alveoli of the primary lobule. Remember, this is the same thing as the respiratory zone. That's why I told you guys all the alternate names for the respiratory zone, because I told you in books they're going to use different, and in other materials, they'll use different terms for it. So the alveoli in the respiratory zone will close down. All right, it's just that collapse. So sometimes it's just the alveoli in an area that are collapsing. Other times it can sort of be more widespread and be a whole segment of the lung, right? And so when you're seeing that, that's something that's causing that whole segment of the lung to close down. That's pretty significant. That's something that would decrease their oxygen levels. That's something that would increase their shunting, right? That's something that we need to take care of. And eventually it can move to whole lung lobe. And that's where that can be pretty significant. And up in this picture on the right side, or it can be the entire lung, which is severely rare for atelectasis to be on an entire lung, but it can absolutely happen. Let's say they intubate someone and they go to the right lung. Well, that left lung, not getting a lot of gas, could be completely atelectatic or mostly atelectatic there. So the picture on the right of your screen, I put this in here. This is a PET scan overlined with the CT scan. So they did a CAT scan and they did a PET scan, and they're looking at areas of high metabolic rates. And that's why you see the brain up here. Everyone see the brain? Your brain, they use a glycogen analog, or glucose analog. And your brain almost runs completely off of glucose. That's why if you're really starving or hungry and all that altered mental status, right, your brain loves glucose to function. But when you're looking at these, you're looking for areas of high metabolic rate. So here on the CT scan, you can see that area of high metabolic rate there. This is a carcinoma. So this is a squamous cell carcinoma that cause atelectasis. So this is pretty much a tumor here. that caused the rest of the lung tissue, if you look on the right side of your screen there, to close down and become radio opaque on X-ray, right? It caused it to collapse, right? It's something is blocking, that little nodule is blocking gas flow from going into that area of the lung. So this is the left upper lobe that you're looking at there. Now remember, on the CAT scan part here, it's a mirrored image, so that's why this is the left and this is actually the right side. So just remember that when you're looking at the picture on your right here compared to the picture over here where they put the PET scan and overrode the CT scan. So here is the left and here is the right. So it's not a mirrored image there because they overlaid the PET scan, but they overlaid the PET scan and the CT scan here, and it mirrored it. So just so you're aware of that there, not something I'll test you over. But you sort of see how something's blocking gas flow there, and it causes collapse downstream. It's like putting a dam in a river, right? You have a river, it's flowing nice and strong, you put a dam there, it stops the flow, and then therefore the subsequent result downstream is very, very little. Very little water will then flow downstream. Well, that's what you got here. Something's blocking that in this case. So let's look at resorption versus absorptive atelectasis. So there are a little bit of a difference here. Usually the postoperative or resorptive atelectasis can be associated with secretions and mucus plugs. So remember, we're shutting down the mucociliary escalator with an operation, right? They're given paralytics. We're talking general anesthesia here. They're given paralytics. It stops their mucociliary escalator from functioning. So this means that they're more likely to have retained airway secretions and mucus plugs, especially if they have an underlying condition like bronchiectasis or chronic bronchitis, right? So if you have a COPD that has chronic bronchitis and they undergo a general anesthesia procedure, are they at high risk from mucus plugs? Absolutely. That's one of the reasons why you have to be very concerned with COPDers in general anesthesia, is because of their higher ability to have their lung function be altered by the surgical procedure. Not by the surgical procedure itself, but by the anesthesia that goes along with that surgical procedure. And that's why we're trying to use more conscious sedations, a little more nerve blocks, more things that won't require general anesthesia if we can. But in this situation, obstruction will develop, right? Because you got a giant mucus plug, similar to that previous screen where we've seen that carcinoma, that squamous cell carcinoma blocking gas flow. This is just a giant mucus ball that's blocking the alveoli from getting gas flow altogether. So then we have this alveoli, we have this giant mucus plug. Obstruction develops. All the gas that's in the alveoli here, that is distal to the alveoli, all that oxygen that was in here, is then going to be reabsorbed by the capillary blood, right? If there's oxygen there, it'll be reabsorbed by the hemoglobin and some of it will diffuse into the plasma. If there's some CO2, in theory, it can go in there. But remember, the pressure gradient for the CO2 is very low. It diffuses 20 times more, but it's a low pressure gradient, right? Remember 46 torr or 46 millimeter mercury compared to 40 millimeter mercury. So it's pretty low, so you're not going to have a lot of that. So a lot of the times here, the oxygen gets reabsorbed into the bloodstream, which means now there's less gas in the alveoli than there was before. So if there's less gas in the alveoli than there was before, then our subsequent result is going to be collapse of the alveoli, right? And so that's what you're looking at with this guy. That gas has then been reabsorbed, and this causes resorption atelectasis. So it goes from here to here, right? You see that change where it sucks the gas out of that respiratory zone, and then it sort of just becomes collapsed, atelectatic on itself, right? So it's non-ventilated, it's collapsed. So do we still have perfusion through this area? Absolutely. We have perfusion without ventilation, which tells you this is a shunt-like condition. So that's what we're looking at there. All right, so this is postoperative atelectasis, passive or resorptive or absorptive atelectasis. So resorption means you have a giant mucus plug. So would airway clearance therapy be helpful in this? Absolutely. Right? Airway clearance therapy, get that mucus out of there somehow. Passive atelectasis or absorptive atelectasis means we're not breathing deep. So let's say we have this person here. This is your normal ventilated alveoli. And then let's say they take a little too much of their Percocet. And they're not breathing very deep at all, right? They're not pulling high negative pressures with their pleural space. So that means that this negative pressure is out there. So this alveoli is going to have less distending pressure and it's going to collapse in. So this is sort of a person that's passive. They're not breathing deep, right? That's that reduced alveolar ventilation. They're not getting it to their respiratory zone. They just have that very light, very passive, very absorptive atelectasis. Is this one caused by mucus plugging? No. Right? So we have resorptive, mucus plugging, absorptive, lazy. I don't know. However you want to remember it. Passive, right? Atelectasis versus resorptive atelectasis. The third one is compression atelectasis. This one was the easiest one to remember, right? And I'll show you examples of all of these, right? When we're looking at compression atelectasis, right, if I have my chest wall, and then I have my lungs, and I develop a massive pleural effusion in my right lung. What's going to happen to that tissue, right? I'm going to have a lot more pressure, especially if it's exudative pleural effusion where it's high in proteins, like an infection. If I have a giant exudative pleural effusion, what's going to happen? Who's going to win this battle? The lungs, which are already introverted to begin with. The lungs naturally want to collapse. Or will the lungs win? Will the lungs be high enough pressure to push away that pressure? Well, no. The lungs are just going to end up being pushed in, right? We're going to see that the lungs start to collapse in because of all that external pressure on them. So that's that compression atelectasis. Anything that squeezes the lung tissue. So this could be a tumor, could be a pneumothorax, could be a hydrothorax, could be a pleural effusion, could be a number of things. So pleural disorders is the first one we talked about. Empyema, remember that's that pus and that infection in the pleural space. Hemothorax, chylothorax, chyle that's developing in there. Pneumomediastinum, pneumothorax, right, that's the PTX there. So there's a number of things there. Remember, there's also other things that are out there like obesity. That's right. So that's one of the things that you have to be concerned about. If you have someone that's morbidly obese and we put them on mechanical ventilation, will their lung tissue expand like someone of their ideal body weight? No, right? And so it's something we have to be cognizant of when we do mechanical ventilation down the road. So I'm not expecting you to remember this now, is what's their baseline state, and should we be ventilating them the same way as someone that has a normal baseline state? So that's something just to be concerned about. But remember, morbid obesity, third trimester of pregnancy should be in here. Not with morbid obesity, right? But remember that the baby can push up on the diaphragm and actually cause compression in lower lung volumes as well. So that should be over here. So third trimester. So that should be on there as well. So when we're looking at anything that can cause that compression, flail chest, which is one of the restrictive disorders that we'll talk about later on, flail chest means you have, here's a sternum, then you have ribs here. So you have at least a double fracture in 3 adjacent ribs, and that's what causes flail chest. So we'll get into flail chest pretty soon here. So what happens here is every time you try to take a negative pressure breath, this area will get sucked in. This chest wall area will get sucked in and compress the lung tissue itself. Because remember, we're generating negative pressure with an inhale. As long as they're not on a ventilator, they're generating negative pressure with an inhale. Because the rib cage has been compromised in 3 adjacent ribs by double fracture, then that's going to cause that area to be sucked in with inhalation and actually push on that or compress the lung tissue itself. So that's what it's talking about with flail chest. Hernias can easily go up and do this, like hiatal hernias, kyphosis, scoliosis, kyphoscoliosis, pectus excavatum, which is that indentation of the chest wall, congestive heart failure. Remember, we have a giant left ventricle. What's the left ventricle going to push up against? We have a giant muscle pushing up against the lung. So who's going to win that battle, right? The lung's already introverted to begin with, so the heart's going to actually cause the left lower lobe atelectasis. Cor pulmonale can easily do the right lower lobe as well. And then, of course, I wrote in 3rd trimester. That's easily one of them as well. All right, so what puts you at risk for postoperative or passive, right? So you're more at risk for postoperative if you already have decreased mucociliary transport to begin with. So this is very common in people that have a history of smoking, right? A current thing is smoking. COPDers, people that have excessive secretions already, people that have things like cystic fibrosis. Easily someone that's dehydrated, because if you're dehydrated, you're solid in your gel layer, and remember, 95% of this whole mucociliary thing is made up of water. So if someone's dehydrated, are they going to be able to clear secretions? Are the secretions going to be nice and thin and easy to move, or is it going to be thick, sticky, and hard for the cilia to move? It's going to be thick, sticky, and harder for the cilia to move. And so that's why hydration is going to be a big key factor. That's why we had patients on a ventilator with mucus plugging. One of the things I would ask is, how much IV fluids? What's their positive, negative? If we're giving diuretics that take fluid off of the patient, watch out for mucus plugging, right? Because that can be some of the things that we might have to worry about here. Patients that have a weak or absent cough, especially after surgery, for sure that means secretions tend to stay into their lungs. People that have undergone general anesthesia, those are usually surgeries over 2 to 3 hours as well. Smoking history, we've already talked about that. Gastric aspiration, easily, because that can cause a pneumonitis and shock everything. Anything that has a thoracic or upper abdominal procedure can put them at very, very high risk for this, right? Because they can't get good lung expansion, they might develop postoperative atelectasis, and then if that continues to fester, could lead to a postoperative pneumonia, and that's a huge deal out there in the hospital system, is preventing a postoperative pulmonary infection. And this is where you're going to be spending a lot of time doing hyperinflation therapy and airway clearance therapy with these patients that have otherwise maybe healthy lungs, and they're going to be like, I don't need this, and you're going to be like, yes you do, because you don't need a pneumonia, right? So when we're looking at, that was resorption, absorptive atelectasis, that means you're not able to get the alveoli, remember, expanded. And I just used a case of overdose, but there are other things. If you have something called pulmonary edema, where you have a bunch of fluid that's leaking into the alveoli, that fluid is then diluting the surfactant that helps neutralize surface tension. Remember, it's diluting Laplace's law. It's causing Laplace's law to take over. So it's diluting the surfactant that keeps that area expanded. It's diluting it, and so that way it leads to more atelectasis. So that's one of the big issues you have with either cardiogenic, which means the heart's not pumping and blood is backing up in there, cardiogenic pulmonary edema, or non-cardiogenic pulmonary edema. Let's say we gave someone a ton of fluids. Let's say someone came in, their blood pressure was really low, and we gave them 5 liters of fluid, right, in their IV. Now I'm just making up that number, right? We give them 5 liters of fluid IV. Well, that's a ton of vascular volume that could easily overload their blood vessels. When we overload the blood vessels, you have more osmotic pressure, and so we need to relieve that pressure, and they might leak into places like the alveoli. So that'd be a non-cardiogenic pulmonary edema. So pulmonary edema of either type can easily dilute the surfactant and then cause atelectasis. A syndrome called ARDS, acute respiratory distress syndrome. This is where you have a bunch of cellular mediators, and we'll talk about this in this class, that ultimately it does cause pulmonary edema, right? There's a pulmonary edema component, but you also have a bunch of pus that gets created and made and put into the alveoli as well. Of course, all that's going to dilute the surfactant and the ability to expand, and that's going to hurt it. Smoke inhalation easily, especially because you don't want to stimulate those J receptors and keep coughing. Thermal injuries, so inhalation burns. General anesthesia, we already talked about that, with low lung volumes and nitrogen washout because of the nitrous NOS that washes out the nitrogen. Neuromuscular disorders like Guillain-Barré, myasthenia gravis, SMA, which hopefully you'll talk about that more with pediatrics class as well. Depressed or even spinal cord injuries too. Depressed respiratory drive overall, that could easily be a neurologic thing like what I was talking about with a narcotic as well. So neuromuscular disorders can include things like this as well. Spinal cord injuries might also be a cause of passive or absorptive atelectasis. That's why one of the things when we put people on that have a spinal cord injury that are tetra or quadriplegic, one of the things we have to do is hyperinflation therapy with them to help avoid pulmonary infections as well. All right, bedside evaluation. What will this patient look like when we're looking at these type of things? So you have your PEMA scrubs on, your PEMA stethoscope. You're in the ER. What would a patient or post-op, right? You're in a room. Someone has a post-op hip knee surgery or post-op abdominal surgery, and they're like, "Hey, we think this person is not doing well. Can you go in and check on them?" Well, what would they present like? Well, they'd be breathing fast. Oftentimes, they'll have pain associated with it, especially the sort of like a pleuritic. It's sort of like that chest pain that can go along with a lot of atelectasis here. They might have a fever too, especially if this has been going on for a while and closing down that tissue to tachycardia, hypertension, cyanosis. So these are all things that you can see as part of that bedside presentation with atelectasis. So other things that you'll see, you'll have an increase in firmness. Remember, anything that increases the density of tissue will increase firmness. The dull percussion note, because there's more dense tissue. Bronchial breath sounds, because there's more dense tissue. Diminished sounds, of course, they're not able to get their respiratory zone to expand at all, whether it's because of a mucus plug, because of a compression, because of low drive or neuromuscular, right? There's something that's not allowing it to expand, so the lung sounds will be very diminished. You won't be able to hear very much air moving at all, right? Especially if there's atelectasis with mucus plugs, you're really not going to be able to hear much moving at all. You might hear crackles on late inspiration. That's sort of like a key thing of atelectasis is they're breathing in as they get to end inhale. As they get to end inhale, you'll start to hear that little popping or crackling. That's usually a sign of lung tissue popping open, right? It overcame its surface tension forces to pop open, and you're hearing that little pop from it, that surface tension, that critical opening pressure finally being achieved. And of course, whispered pectoriloquy. Remember, increased density, more likely to have whispered pectoriloquy. Okay, on X-ray, this is where we'll usually see it most commonly. You're going to have an increased density, so it's going to be more radio opaque. There might be air bronchograms. Remember, air bronchograms are really non-specific. They just mean something intrapulmonary is confirmed to be going on. So it's usually a pocket of gas surrounded by either by something dense, whether it's mucus or inflammation or collapsed tissue. You're going to have that air bronchogram in there. Elevation of the hemidiaphragm on the affected side. Remember, it's collapsing tissue, so the diaphragm is going to move on up, right? It's going to suck the diaphragm with it, that collapsed tissue. There's going to be a shift towards the affected side. So if I had a pair of lungs, and then this was my left lung, and this was my right lung, and I had a massive amount of atelectasis develop in my right upper lobe. So this is an intrapulmonary condition. If I had a massive amount of atelectasis going on there, and we'll put negative pressure in the pleural space. If I had a massive amount of pressure, negative pressure on the outside pulling, am I able to expand this collapsed area in my right upper lobe? Am I able to expand that area with negative pressure as easily as I am the other areas? I'll ask that again. Am I able to expand this dense, collapsed area as easily with the same amount of pressure as these other areas? Absolutely not, right? So this area here, this right upper lobe, is going to stay collapsed, right? It needs more pressure for that area to open, but that's not how things work. There's other areas that are opening up. So if I have this pressure and I'm opening up my lungs, I'm expanding my lungs, what's going to happen with my trachea, my main stem? What's going to happen with all these guys in the middle? Well, they will all deviate which direction? Towards the atelectasis or away from the atelectasis? Now remember, with negative pressure breathing, the lungs are expanding out. They're going to be sucked towards it, right? They're going to be sucked to this bad area. So if it's in the lungs, it's sympathetic. It pulls towards it. It goes towards it because the other areas are expanding, and this is going to create pull, right? And it's going to pull tissue towards it as other tissue pulls away from it. It's going to stretch it. So if it's intrapulmonary, the trachea, the main stem, the central parts of the airways will actually pull towards that collapsed side. So this is that mediastinal shift towards the affected side. This is a board exam situation. The way that I remembered it for the board exam is if it was an intrapulmonary condition, it always goes towards it. If it was an extrapulmonary condition, like a giant pneumothorax, it pushes the mediastinum, gets pushed away. It gets curved away, right? And we've seen that in the Xray evaluation video with the pneumothoraces. You've seen the trachea and mainstem, all that stuff be pushed away because there's something outside that's compressing and shoving the tissue towards that area, right? It's pushing it away from the affected side. So in this person down here, this is a pneumothorax, and so the mediastinum shifting away. Up here we have atelectasis, and it's going towards the area of atelectasis. So if it's outside, it's stranger danger. It runs away. The mediastinum goes the opposite direction. If it's inside, it's sympathetic. It wants to go with it. They will ask you that. That's something you'll have to know for the boards, is which direction the mediastinum shifts with the pneumothorax. Which side it shifts with a massive intrapulmonary condition. So hopefully you can start working on that now, get that down however you desire. But I always remembered stranger danger, runs away. The other one is just the opposite, it goes towards it. So however you want to do it, go for it. Alright, so this is an Xray, took off the internet, but this is an PA and a lateral Xray, and you can see how on this right lower lobe, you can even see the fissure. You guys see the fissure? Fissure is usually a sign of a collapsed lobe altogether, and you can see on the lateral. Collapsed lobe altogether, and so what you're looking at here is a situation where this whole right lower lobe is just collapsed. and you even see the diaphragm is elevated, right? We have an elevated hemidiaphragm there. And what do you notice about the trachea? Is the trachea being pushed away, or do you think that the trachea is actually being pulled in? You guys see this? Which direction do you think the trachea is going? Up here? Yeah, their neck's curved, so that's not helping us out any. There's their left main stem, their right main stem. Which direction do you think this sucker is going? Well, that left main stem is still pretty set there, but you can see how that right main stem, how this mediastinum is actually being pulled a little bit. It's more common in the middle to lower lobe area here, but that's that mediastinal shift towards that area of atelectasis that you're seeing. It's pretty bad. Here is another episode of massive atelectasis. This is one that I took from your book, I believe. The left lung is pretty much misplaced because the left lung is pretty much massively collapsed because the endotracheal tube is placed in the right mainstem bronchi. Remember, the right mainstem bronchi is about 25 degrees, and so compared to 40 to 60 on your left mainstem. This person has other issues going on, but the endotracheal tube is too deep, and so that means gas flow into that left lung is almost non-existent, which means we have a whole lung atelectasis pretty much going on here. So the same patient, they did 20 minutes later, they got an X-ray. You see a lot more radiolucency afterwards, a lot more radiolucency. So they were able to move the ET tube back to the level of the carina. That's what that area is pointing back above the level of the carina, which is right here. Hopefully you guys can start identifying the carinas on X-rays. So the ET tube was moved back to up here above the carina, and so that's why they were able to get some airflow to go in here. Down here, it was definitely below and into that right main stem. Alright, so what would an ABG look like on atelectasis? Well, if it's very minor, small compression atelectasis, or so on and so forth, if it's very mild atelectasis, you might get some respiratory alkalosis. Remember, they're going to be tachypnic, and that's that shunt-like effect that's going on with it that you're seeing. And so that's just that initial respiratory alkalosis from that cyanosis, that shunting effect of the hypoxemia. If it's widespread and massive, they'll go into a respiratory acidosis. And so that's a big issue here. How widespread is it? The patient's at the bedside, they're working hard to breathe, they're sweating. They have a massive 4-liter pleural effusion on the right side and a 3-liter on their left side, right? They have a lot of compression atelectasis, more massive than what we see here. Just pushing in on all that lung tissue. Well, you draw that blood gas and then they're in a respiratory acidosis. That's a sign that this is a very severe widespread atelectasis going on. Alright, so the patient picture that I just gave you on that last slide with the massive pleural effusion, you're not going to be doing a PFT on them. That's why you use the ABG to sort of quantify how severe their condition is. Now, let's say we got a patient with atelectasis and the doctor orders an outpatient pulmonary function test or a bedside pulmonary function test while they're in the hospital, and they just sort of want to see how their lung function's doing with their atelectasis to quantify it that way. So this is someone that doesn't have like shortness of breath, 3-word dyspnea, right? We're talking about someone that's more on the stable side of health than the unstable side of health. So this is a restrictive pathology. So therefore, even though there's mucus plugging involved, it's still restrictive pathology. So therefore, all your volumes are going to be decreased. What about your flow rates? Like your peak flow rate, your 200 to 1200, 50%, 25 to 75, right? Those are going to be normal. FEV 1%, and this one's like, okay, what's this one? Well, normal or increased. Why is that normal or increased? If you're curious, and I know you are, the FVC, the capacity of the lungs, is decreased, right? We talked about this being a restrictive disorder. So if the FVC is decreased, we're taking FEV1 over their FVC. This might be a higher ratio because their FVC is decreased. And I hope that makes sense. But overall, because their FVC is decreased, that's why the FEV1 actually might be increased. It's not because their flow rate improved, it's because their denominator got smaller, right? Because remember, this is the denominator. Your forced vital capacity is your denominator, your numerator is your FEV1. It could either make this ratio decrease by decreasing the numerator, or I could decrease it by decreasing the denominator, right? And so I decrease the denominator in this mathematical situation. Therefore, that's what you see. All right, we already talked about this with the right heart pressures, the left heart pressures, and then what happens. Remember, this is a shunt-like condition. Shunt-like, so oxygen therapy, definitely. DO2 is decreased because of CaO2, I heard it. Right? Your CCO2 is low because you can't get oxygen to your alveoli. Therefore, your CaO2 will also be low, right? Because remember, this is downstream of the CCO2. Therefore, your DO2 is decreased. VO2, your consumptions are going to be normal. And then your extraction ratio is going to be increased because your DO2 is decreased here, right? It's not a metabolic thing. And then your venous saturation is going to be decreased because your CCO2 was low, therefore your CaO2 is low, therefore your venous saturation will be low, right? It's all downstream from there. All right, so we're not going to talk hemodynamics on this one. The hemodynamics, the right-sided heart pressures, if there's severe atelectasis with cyanosis, it'll cause your right-sided heart pressures in theory to go up, and left-sided pressures should be normal if it's causing hypoxic pulmonary vasoconstriction. So right-sided heart pressures would be increased. Left-sided would be normal. When we're looking at therapeutic interventions, oxygen protocol is going to be one of the first ones that we'll give, just to help them get the right amount of oxygen into their bloodstream. Lung expansion therapy is going to be a big one here, whether it's PEP, positive expiratory pressures, continuous positive airway pressure, PEEP if they're on a ventilator, positive end expiratory pressure, some sort of device that gives them pressure. And down here you'll see a picture of a metaneb, and it's obviously proprietary. And this device, not only does it give pressure, right? We can set it to give pressure for a couple of breaths to help expand lung tissue, but we can also set it where it oscillates, where it does sort of a clapping or a oscillation. It sort of does like beating someone's chest, right, for therapeutic percussion. To help unstick secretions. It does both of those things, so it can give pressure and or do oscillations while delivering a nebulizer. So the cool thing about this type of device is if someone has a lot of atelectasis secondary to secretions, which is what type of atelectasis? Mucus plugging secretions? Which type of atelectasis? Absorption or reabsorption? Hopefully you got that one right. Then we can do both. We can expand the lung tissue and help clear secretions. So that's one of the cool things. So if they have the type of atelectasis that needs airway clearance, then we can work on that one. Bronchodilators obviously as needed. Remember, bronchodilators not only improve the structure of the respiratory zone when it's collapsed, because the smooth muscles around the alveolar respiratory zone and gives it structure, and that would help expand tissue, but it also helps ciliary motility improve as well. Patient positioning too, especially if they have compression atelectasis. Let's say they have a massive 3-liter atelectasis on the right side of their thoracic cage, and on the left side they don't. So if we lay them on their right side down, so we lay them on the right side, where the compression is, the left side actually has better expansion because it's not being crushed by someone laying on it. So they actually might have better oxygenation there. So patient positioning can help, especially if there's compression. Atelectasis, pain control, especially if they're having issues with pain where it hurts to take a deep breath. Then if they get pain medicine to help them so they are not scared to take a deep breath, that can work too. Some patients that are post-operative, we might have to coordinate with the patient care staff, like the nursing staff, to see when they get their medicines. So that way they'd be more likely to comply with the positive pressure devices that we're using. So, hey, they're getting their pain control pill at 10 o'clock. So at 10:15, 10:30, that's when I come into the room. I give them this expansion therapy because it's going to hurt otherwise, right? And then finally, one of my favorite ones, ambulation, right? Get them moving, whether they're sweating to the oldies or not, get them up and moving. That helps them breathe deep and they don't even realize it. We can do as many of these therapies as we want at the bedside, and that's great as long as they're complying with it. But if they get up and walk around, their body's naturally going to have to breathe deeper and move and get that cilia up and running. It's just a big win-win when we start to get people ambulating as far as lung function goes. All right, quick review questions. What are some of the common lung alterations that occur with atelectasis? All right, you're called to the bedside of a patient that's having a hard time breathing, their oxygen levels are low, and they think they have atelectasis. What would their presentation be? Would they be tachypnic, tachycardic, cyanotic? Would their sputum be different? What would their percussion note be? What would their breath sounds be like? What would show up on their chest x-ray? They had very mild atelectasis. What would their ABG look like? If it was widespread, what would their ABG look like? What type of condition is this? What does it do to my oxygen extraction ratio? What does it do to my DO2? What does it do to my CO2? What does it do to my body? What is my physiological response to this? If I had a patient with atelectasis and it wasn't severe, what would I see on their pulmonary function test? Volumes, flow rates, what would I see there? Okay, we've confirmed this patient has atelectasis. What therapies would be indicated? What would you give this patient to help them resolve this situation? They're asking you, what are your recommendations? What would you recommend therapeutic-wise for this patient? All right, what are the 3 general types of atelectasis and what's associated with each one of them? You should have this down, right? Start putting this picture together, start putting a mental patient scenarios together. That's why I have you guys do those tables. It should be helpful to sort of see the presentation and the minute differences between different presentations.